Hi everyone, and welcome to today's video where I'm going to go into the differences that I've personally found between secondary care pharmacy, which is hospital-based pharmacy, and primary care pharmacy, which is pharmacists that work within GP practices. The general kind of like agreement that we all had within hospital was that you would be stepping down to primary care. So I always thought that primary care would be easier than secondary care, and because I had done so many rotations in hospital, I would be okay in primary care. However, I've not found it to be the easiest transition. To be honest, I've actually found it quite challenging, and it's two very different ways of working, and I've learned a lot in the process, so I thought I'd try and share those today throughout this video. So the first main basic thing that I noticed was that obviously there's no on-call in primary care. So in hospital there was on-call. You could be called at any time during the day, any time during the night, any time during the weekend. So when you are working, you kind of have less of that boundary between work life and non-work life. Whereas in primary care, you do get those kind of set hours, and you're not working the weekends, and no one's calling you up in the middle of the night to kind of say, I need a medication, come into hospital, that kind of thing. So there is less urgency within primary care in that aspect, but I think that I definitely learned a lot during on-call, so I would never tell anyone not to do it. The work-life balance is probably better within primary care, but some people would not find that, I guess, exciting enough or challenging enough, the way that hospital gives you that like adrenaline rush when someone calls you at like 3 a.m. The second difference that I found was the difference between long-term sustaining fixing an issue versus immediately fixing an issue. So in hospital, if a patient comes in and, for example, they have a stroke, you need to solve that issue right now. You need to get that medication to the patient right now. You can counsel quickly, briefly on how to take the medications when the patient's going home, but that's it, and then they're out the door. Whereas in primary care, you might not just be solving an infection or solving an issue there and then, but you also have to think about sustaining it. The best example I can give is if you're starting a medication for a patient in primary care, you might need to monitor baseline bloods, and then bloods 3 months later, 6 months later, 12 months later. You're kind of long-term overseeing that patient's care. Whereas in hospital, we usually try and get them in and try and get them out. So I found that very, very different. The diagnosis style is very different. So in hospital, the doctors will be doing the diagnosing, and you'll just be told this person has come in, they've got this, we found out this, they've investigated this, so the medications we've prescribed is this. However, in primary care, as you are the one who faces the patient, they might have come in for a medication review, but they might tell you about something else. Obviously, it's not inside my competencies to be diagnosing people, but you have to kind of have like some sort of idea of how you're going to manage that patient. So if a patient comes in and says, these are the medications I'm taking, however, I do want to mention this other problem, you need to be able to kind of deal with that and ask the right questions. So take a history and ask them how long they've had this issue, if they've tried anything for this issue, if they've spoken to anyone already about this issue. That kind of conversation I never really had before in hospital, really. So that was very different, the diagnosis style. Either way, I'm not diagnosing in hospital, I'm not diagnosing necessarily in primary care, but in primary care, you need to be a lot more switched on when it comes to the diagnosis, because you need to watch out for the red flags. You need to make sure that you can escalate it properly, because you're that patient's first point of contact, if that makes sense. Which leads me on to my next point, which is that the time spent with patients is completely different. So in hospital, you might be running like 2 to 3 wards, in which case you are not going to have time to sit and talk to every patient about every single thing and issue that they've got. Most of the time, you're reviewing the drug charts, fixing like prescribing issues and supplying the medication and trying to stay on top of managing, you know, your 60 beds or whatever. Whereas in primary care, you are the one who speaks to the patient directly. So they're right in front of you, you have consultation time, and you really got to hone in on your consultation skills, basically. It's not just what medications are you taking, do you have any allergies, did you bring any of your medications in? It's not kind of like a whistle-stop tour. It's more like a serious consultation one-to-one with the patient. So you have much more patient interaction. Ideally, we all would in secondary care in hospital as well, but that just doesn't tend to be the case, obviously, due to how busy everybody is. Team size. I really struggled to adjust to the team size thing. I like big teams, and I really enjoyed lunches in hospital where I didn't know who I was going to have lunch with that day. And you could be in the canteen and anyone could walk in and you would just have lunch with different members of people, different professions. Whereas obviously within a GP practice, there's your GPs, there might be a physio, there might be a PA, there might be some other pharmacists, but the team number is definitely not as big as in hospital. Yeah, I definitely missed the social aspect of hospital pharmacy. There was more of a community, I guess, and every lunch was just different. But it's harder to establish that in primary care. The team is so small and the team is the same every single day. Yeah, I found that very, very difficult to adjust to at first. Sole decision making. So I honestly thought that I was prescribing in hospital, to be honest, because I would amend so many prescribers' mistakes or recommend something else and just check the guideline and advise doctors that that's not the right treatment pathway or whatever. But ultimately the decision at the end of the day was down to them. And if the consultant said, we're going to go down this route and this is why, it was quite difficult to challenge that. Of course, if you really were against it, you would challenge it. But I thought I was prescribing essentially in hospital, but I realised since coming to primary care that I definitely wasn't. In hospital, you're the one who's checking the doctor's work and you tell them what they've done wrong. Whereas in primary care, I found that it's the other way around. So because I'm the one who's had contact with that patient, I might be the one who identifies something and then escalates it, and then I have to take it to the GP, and the GPs will say to me, okay, this is what you've documented, this is the way that I would have gone about it, and it's the doctors that check what you've done. So I always was used to checking what the doctors had said and doctors had decided and being like, I would have done it this way, or recommended something else. Whereas in primary care, I found that it's the GPs checking my work, which has been an adjustment, because I'm not used to someone checking me. I'm used to being the one who's checking, but it's just a different way of working, basically. Discussing diagnosis and blood results with patients. In hospital, I would never tell a patient you've got a certain condition or a certain disease. In hospital, I would rarely ever, in fact never, I would never tell a patient what they've got or what blood results mean, and the doctors will be having those discussions with the patients. Whereas in primary care, we'll be the one who, for example, looks at a HbA1c score and then decides actually this patient's had 2 HbA1c scores in succession, which indicate high blood glucose, and they're getting symptoms of diabetes, and therefore you might have to be the one who's having that conversation with the patient. The insane amount of detail in primary care has blown my mind. So in hospital, if a patient has low or high blood pressure, it's a very small part of the puzzle. So there's a lot more going on for a lot of the patients, and there's a lot of different staff members looking at a lot of different things. So for example, a dietitian might be talking about nutrition with the patient, the doctors will be talking about what's going on with the patient, we'll be discussing medications. Something like blood pressure would be a quick scan of the observations chart, and then you would just say to the doctors, this person's blood pressure is high. And it's a very, very small part of what usually is something more serious that's going on. Whereas in primary care, because we're the ones who are preventing disease, you've got to know about disease prevention in a lot of detail. So it was literally all about digging up my university notes again, memorizing the different types of ways to diagnose hypertension, referring patients to community pharmacies to get 24-hour blood pressure monitors. And what I'm trying to say is that, whilst in hospital you might just say this person has high or low blood pressure and tell the doctors, in primary care you need to be able to identify it, refer patients appropriately, advise on red flag symptoms and refer them on for diagnosis, and then be able to call them back in to follow up on what the results were. I think I know a hell of a lot more about long-term conditions now than I ever did in hospital. The follow-up of patients is really different. So in hospital, you will have rarely any opportunity to follow patients up unless they're readmitted, I guess. You see them, you do what you can, you get them well and you get them home. Whereas the follow-up of patients in primary care is you can follow up and call them next week. You can follow up and call them in 2 months' time, 3 months' time. You get more time to follow up and you get the opportunity to follow up properly. And so you're essentially on a journey with the patient for a longer period of time than you are in hospital. Which also leads me on to the next point, which is actioning what we've been told. So in hospital, I'd be the one who says, GP, please monitor LFTs, FBCs, blah, blah, blah on this medication. Whereas in primary care, us pharmacists do read those discharge summaries, and we're the one who has to actually action what the hospital wants. So again, you're just acting in different roles essentially. So I was used to giving the commands like, please follow this up by, whereas now I'm the one who's getting those instructions and I'm the one who has to action those. Another difference is that you'll get different rotations in hospital. So you will get a detailed idea of how a, for example, maternity ward runs, or how a renal ward runs, and what kind of patients are in those wards and how to manage those patients. And that'll be what you add to your CV, I guess. Whereas in primary care, you will be learning through competencies and adding on kind of diseases. For example, now I am trained in hypertension, type 2 diabetes, contraception, hormone replacement therapy, thrush, ADHD reviews, medication reviews. And so it's kind of like a list of diseases that I'm trained to see. Whereas in hospital, it's based on rotations rather than diseases. So that I found very different as well. Overall, it's been a really different way of working. And I don't think it's a step down, to be honest. I think that both hospital and primary care really offer different skill sets. I think both are so important. My best recommendation to everyone would be to try and get some experience in both. And I wouldn't say that one's actually easier than the other. Yes, work-life balance is better within primary care, but clinically I wouldn't say it's easier, because you are by yourself in a room with a patient. You kind of do have to know the answers there and then, and you're the one who has to escalate something if something goes wrong. So yeah, it's very different ways of working. I'm glad that I've got experience in both. I think we should all be given the opportunity to have experiences in all different sectors of pharmacy, and that's all I wanted to share. I'm sure there are a lot more differences, but those are the ones that I came up with. If you guys can think of any more, then let me know in the comments, and I hope that you enjoyed this video. Bye!